So this 10 a.m. panel is on infrastructure, and we're going to be examining the use of public health and engineering tools to understand how COVID-19 impacts our community's health and well-being, and in particular, the implications for our built environment. My name is Ann-Marie Conrado, and I'm an associate professor of design from the Department of Art History, and Design, and a concurrent faculty member in the Department of Anthropology. It's a wonderful opportunity to be a part of this kind of community forum, to examine research, to promote dialogue and discussion amongst community members. And I really want to thank the organizers of the forum, including Notre Dame Research, the Health and Wellbeing Initiative, the Notre Dame Office of Clinical Partnerships, the Social Determinants of Wellbeing Taskforce, for all together coming and convening this kind of community-focused research forum. And I really want to thank you all who've taken the time out to participate today. I'm honored to moderate a panel on infrastructure and bring together two esteemed panelists from our Notre Dame community. Now, before we get started with their presentations, I want to remind and encourage everyone that we are monitoring the chat channel and to type questions at any point into the Everyone chat box. And we hope to bring those out in a robust discussion after these presentations. Make sure not to send those questions in any private chat because we're not monitoring those. And if there are more questions and we'll have time, then we will try to follow up after the panel. Now, for our first presentation, I want to welcome Dr. Marie Lynn Miranda, the newly minted Charles and Jill Fischer Provost of the University of Notre Dame, and a professor of applied computational mathematics and statistics, who has stepped into her new role in the midst of a maelstrom of a year to oversee our academic enterprise. Along with her, I want to also welcome Rashida Callender and Jocelyn Johnston. Together, Dr. Miranda and her team are here to discuss the Indiana COVID-19 Registry, a real-time effort to track and measure not only the virus spread, but the community impacts in its wake. A warm welcome to you all.
Thank you. I'll get us started, but then Jocelyn and Rashida will do the presentation. Jocelyn and Rashida, I'm not sure which one of you is going to share your screen, but you can go ahead and do that. I'll just start by saying I have to do my standard plug about the fact that I have a researchers and a personal objection to the term social determinants of well-being or social determinants of health. I don't think they're determinants. I think they're correlates. If they were determinants, it's not clear to me that I would ever have become the provost of Notre Dame, and there may be a few others of you who sort of share my view of that. So Jocelyn and Rashida, who are two critical members of my research group, are going to present the Indiana COVID-19 Registry. It's built on a registry that we originally built in the aftermath of Hurricane Harvey to sort of understand the long-term impacts of the flooding event there. But the technical backbone that we built for the flood registry was equally applicable for subsequent floods, but also we realized we built it intentionally so that it would be equally applicable for subsequent major events, including things like COVID-19. So we've done a lot of work in Texas already. We've built an analogous registry for the state of Indiana. And with that, I'm going to turn it over to Rashida and Jocelyn to talk about where we are in all of this work and what we're beginning to find out.
Sure. Good morning, and thank you for that introduction, Dr. Miranda. Jocelyn, if you could go to the next slide, please. So I'll start by just providing some additional background on Indiana Registry. As Dr. Miranda mentioned, we've created previous instances of the registry in Texas, but with our research group transition and move to Notre Dame and speaking with our collaborators here in Indiana, we felt strongly about creating a separate instance of the registry for Indiana registrants. So for this registry, our inclusion criteria are first, being an Indiana resident that's 18 years of age and older, And an important point is that individuals can join whether or not they have had COVID-19. In addition to health impacts, we are also looking at economic and social impacts. The registry is set up to where there are intro and follow-up surveys. Registrants create an account for themselves by completing the initial survey. And as soon as they complete the initial survey, a follow-up survey is available for them to complete. So they can return at any time, whenever their status changes, to update and complete a follow-up survey. But we also send reminders, email reminders every 2 weeks asking for registrants to update their status on a 2-week schedule. And our objectives in creating this registry, as Dr. Miranda mentioned, are to first provide real-time information on the impact and spread of COVID-19. And the registry, it is intended to supplement the public dashboards that medical professionals, health systems, health departments are already publishing. So our goal is to collect additional information that health departments, when responding to a emergency situation, don't necessarily have the time to collect. And we're also looking at things like assessing how effective the different suppression behaviors and policy changes are working. And with the information we collect, we are able to look at that across geography. So asking questions to registrants about, are you washing your hands more frequently because of the pandemic? Are you staying home more often, only leaving for essential activities because of the pandemic? So information to supplement what's available on public dashboards. And also looking at deeper research questions about how social and environmental exposures, specifically race, ethnicity, socioeconomic status, and particularly with our research group CHI, we are interested, Children's Environmental Health Initiative, we are interested in factors like air pollution, the built environment, and residential segregation, how those exposures also influence an individual's vulnerability to COVID-19, their risk for COVID-19, and also how the disease develops and progresses. And also looking at how these factors influence social and economic conditions. We ask questions about economic difficulties, mental health, coping ability. So how are these influenced by those social and economic conditions and exposures? Next slide, please. And so to provide more detail on our survey questions, our initial survey is organized into 4 sections. The first being symptoms in healthcare. So our first set of questions asks, have you experienced these symptoms of COVID? There are questions about testing, mental health, access to healthcare in the seasonal flu, but also, and then additional sections are on exposures and behavior, household impacts, and background information. Our follow-up survey includes a subset of questions from all sections, with the exception of background information. That's only collected one time, and that's in the core survey. And I will also say that our survey has changed as the pandemic has progressed and changed. Specifically with our testing question, we initially started off asking only about an active viral test. So not testing for antibodies, but we have expanded the survey to include questions on that. Also, as we've received feedback from registrants, specifically with different economic difficulties, we've expanded that section to capture more experiences. And now, as there is news about vaccinations or vaccines being available, we are in the process of adding questions about vaccinations and then also vaccine hesitancy. And so, as Dr. Miranda has mentioned, we do have an instance of the registry that is based in Texas. Our instance in Indiana, we currently have just over 300 registrants. So to provide a picture of what we are capable of doing and how we use the data we collect, I'll turn it over to Jocelyn, who will start by providing an overview of our research in Texas.
Yeah, thanks, Rashida. So everyone can see on the right side, Harris County is the county that Rice University resides in, and that's where a majority of our participants currently are. But you can see we do have participants from our neighboring counties, which we're also partnered with, such as Fort Bend and Galveston County. And in the registry, we have over 8,000 registrants, almost 9,000 as of November 19th, and this is nationwide. But just as a picture of what we can find out from this data, we're just going to take a focus on Harris County, and we can see that about 4,500 registrants are in Harris County and 3,500 have completed at least one follow-up survey. So we're able to see how their status changes over time. And we do lean a little bit more female and non-Hispanic white, but we have a nice spread in terms of age. So one of our first sections, as Rashida pointed out, was asking them about symptoms. And from the Harris County registrants, we were able to see that 29% of them reported some kind of fever, whether measured with a thermometer or they were feeling feverish. And other symptoms we asked about are like cough, shortness of breath, chills, loss of smell or taste, common symptoms associated with COVID-19. And we shared this in statistic form, also in map form, so we can share with our county partners across geography where are we maybe seeing high rates of fever, so that they wanted to know this so they can plan for testing sites, or if they need to send out mobile health clinics to see where people might be needing help. And this is helpful for testing, but we can also see at the bottom, when we're looking at testing, we want to make sure it's accessible to everybody and making sure that if you have symptoms, you're able to go and get tested to see if you have COVID-19. And while between, maybe you can see on the left, 20 to a little bit over 30% of people have been tested for COVID-19. We're specifically interested in the group on the right, which is people who tried to get tested but could not. And you can see this is very different when you're broken down by race and ethnicity, with non-Hispanic Blacks having the highest rate of being unable to get tested even though they tried to. And this is just the start of trying to investigate these kinds of questions, what kind of barriers might be holding them back. Looking at economic impacts, almost 50%, 46% here in our registry reported losing income in their household, whether it's themselves or someone else in their household, and other economic impacts such as difficulty paying rent, difficulty paying bills, or increased household expenses. And once again, breaking down by race and ethnicity, we can see that our communities are being impacted disparately by COVID-19, not just in terms of health, but in these economic impacts. With the red bar representing non-Hispanic whites, and you can see increases with non-Hispanic Blacks and Hispanics having the highest rate of losing income, and similar disparities in the other economic impacts.
And I will say we'll take a look at our mental health data next. This has been of great interest to our collaborators in Harris County, and a great supplement to the data they're collecting on cases in this geographic area. And so our mental health assessment includes a 7-item self-assessment tool, the GAD-7, which includes questions on symptoms or difficulties that are associated with generalized anxiety disorder. And so 7 questions are asked. These results are used to calculate response. The registrant's responses are used to calculate a score that is categorized into either minimal, mild, moderate, or severe anxiety. And you could see first by looking at the pie chart that about 53% of our registrants have symptoms consistent with minimal anxiety, but about 20% have moderate to severe anxiety. And what we're able to do is track what we've been able to do with the follow-up surveys is track how these scores have changed over time in individuals. And if you look at the pie chart, I will say in July is when we peaked in Harris County. So you'll see in July, there is a sharp decline in the minimal anxiety, but also in the mild and moderate and severe categories. There's also a noticeable increase that you can see by eyeballing these graphs. Also, you could see in our stacked bar chart on the left, which has been smoothed, if you look specifically at the width of the moderate to severe categories, for a period of time from March to August, it was significantly wide, or it stayed around the 20% range. But since then, that has narrowed. So it has been a great help to our collaborators to provide this information into symptoms while they're planning. We've also been able to look at how some of those economic impacts are affecting anxiety. And so we'll see here, reporting income loss, there is a greater frequency of moderate to severe anxiety, whether it is the registrant that is reporting that they've lost income, or someone in their household. And then also individuals who have experienced difficulty paying rent are reporting moderate severe anxiety at a greater frequency as well.
And our final section that we're reporting about will be about suppression behaviors. Specifically, we looked at 3 of the examples of suppression behaviors we have in our survey, such as staying 6 feet away from other people, so physical distancing, remaining home except for essential activities, and wearing a face mask. And we tried to track this over time using follow-up surveys and compare them to different county orders, such as in late May, there was the 4th stay home and work safe order. But as cases were going up in the summer, around the end of June, beginning of July was when Harris County set our COVID-19 threat level to level 1, red, which is uncontrolled spread. And you can see how mask wearing, the green line, has really increased over time, but the red line for people who are staying home except for essential activities, that has gone down, meaning more people are going out. And then you can see also over time, we can track this over geographies. Red, the darker red, means more activity, more going out. And we can see that is getting darker over time. And so just to wrap it up, we want to, of course, thank all of our CHI team. All of them have helped us do this research and launch the registry. And we're thankful to all our research participants, our funders, all our county partners, and the offices of research at Rice University and University of Notre Dame.
And I'll also just put out a call to action or an invite to join the registry. As I mentioned, it's open to all Indiana residents 18 years of age and older who could join by visiting covreg.crc.nd.edu. And I would also like to acknowledge our collaborators. We are based at the University of Notre Dame, but we have great collaborators at Indiana University, Purdue, CTSI, All In for Health, and community health partnerships. And so also, if you are aware of, or if you're representing a community organization and would like to partner with us in getting the word out, or you're aware of a community organization or group health system that would be interested in partnering with us, or this information would be of value to their operations, I encourage you to send them our way. And again, thank you very much.
Thank you, Rashida, Jocelyn, Marie Lynn, for this presentation. I want to introduce our second panelist. And then before I do so, please encourage more questions. I see a lot starting to come in. And I also thank Marie Lynn for responding to those as they come in. We'll also try to fold those into our discussion at the end. But this is live time discussion here, so this is wonderful. I now want to welcome Tracy Kijewski-Correa, and she is the Leo E. and Patti Ruth Linbeck Collegiate Chair, Associate Professor of Civil and Environmental Engineering and Earth Sciences, also an Associate Professor of Global Affairs and Co-Director of the Integration Lab with our Keough School of Global Affairs. And Dr. Kijewski-Correa will speak on joint hazard mitigation in the era of COVID-19 and the implications for design and the operation of the built environment. Welcome.
Yes, thanks, Ann-Marie. And thank you all for being here today. Again, I want to echo my appreciation to the organizers for giving me the opportunity to be a part of a conversation that ponders how we as a university can help lead our planet out of this pandemic. There was a lot of focus in the prior presentation about people, the impacts on people, their behaviors. But what I want to focus now is on places, because they're an equally important part of the spread of COVID-19. And as our project is exploring, places have this really critical role to be a mitigation measure that can simultaneously also promote well-being and flourishing in this new era. So my research takes me into communities immediately after disasters to forensically identify the drivers of their catastrophic losses. Like the Provost team, my work actually took me to look at Harvey, for example, in Texas. But in every case, there's always this really brief window to build back better. It's a precious time after the storm when the eyes are wide open and there is a fresh experience and a focus that's squarely on trying to understand what was lost and how we can make sure that we never return to a way of life that puts us at risk again. And in this regard, COVID-19 is no different. This pandemic has proven expertly equipped to do what disasters do best. And that is to highlight the vulnerabilities in our systems, our processes, and our infrastructure, whether that be physical, social, or economic. And I argue they particularly highlight the ones that we had long chosen to ignore. So we have a chance, once we see these vulnerabilities with fresh eyes, to look at how to design appropriate mitigation measures. And for COVID-19, it was very easy to identify the mitigation measure that's 100% effective against the virus. In fact, I'm guessing that each of us online here today already had this proven mitigation method at our disposal way back in March. Indeed, the difference between exposure to the virus and safety for most of us on this call likely hinged on our homes. And for this reason, homes are actually now the most critical piece of infrastructure in America. They are the nexus for working and learning for a large cross-section of American households. And it was largely taken for granted in this country when the stay-at-home orders were swiftly enacted that we all actually had a place to call home. Even if you neglect the homeless crisis in our country, did you even know that another 1.35 million American households didn't have a place to shelter because their home was severely inadequate or even damaged still from the hurricanes in 2017 and 2018? Further, it's estimated that 1.6 billion on this planet lack access to a safe and dignified shelter. So how do you contain a virus when the basic mitigation measure, the one that's most effective, is not even available to the vast majority of the planet? This spotlight that the virus is placed just so brightly reveals our underinvestment in physical infrastructure, including the right to housing. And so thus, while there may be a tendency to characterize COVID-19 as an exclusively public health issue, the built environment has both mitigated and unfortunately exacerbated the pace of COVID-19's march around the globe, which has called into question now the connection between our current approach to creating built environment and how that relates to the health and well-being of communities. Now, while I'm going to spare you from all the math, science, and simulation that backs an engineer's work, it is important for you to understand at least how we approach design. Everything we build for society is designed for extreme events. It's designed such that if that extreme event were to occur, you won't lose your life. And the key word here is if. Engineers attempt to predict statistically the most extreme event that could impact your community over your lifetime. But these phenomena are random, and they ultimately have us selecting events at the far tails of the bell curve. Imagine events that happen one every 500 years. Once we identify those extreme events, then we go to work determining how they affect each part of our community, and then how we should therefore design each part of our community in response. But this unfortunately requires engineers to be fortune tellers. We have to tell the future in some extent to try to figure out what those extreme events likely will be. And we learn from the past in doing so. So our complete design of your community was framed by the extreme events that conventionally occur over your lifetime. Things like hurricanes and earthquakes, tsunamis and tornadoes. But now, unfortunately, we have learned, and our next learning loop now tells us that pandemics have to be considered as part of this calculus. And that's because there's evidence that suggests that COVID-19 will not only persist, even though we have a vaccine on the horizon, we may even see the recurrence of it and other pandemics in the future. So we're now being called as an engineering community to reimagine how we will design, construct, and operate our built environment for this new form of extreme event. Now, designing for extreme events is very expensive, especially when there's no guarantee of when and how they will actually occur in the future. So thus, to minimize cost, the way we've approached design in our society is to basically centralize all of our most critical services in a select few locations in your community. We deliver healthcare at a hospital. We deliver education at our schools, manufacturing at our factories. And our community then becomes a collection of critical nodes where all of those important activities take place. And that becomes a centralized community infrastructure. And each of those critical nodes in that central infrastructure is designed for a higher level of safety and better performance in those extreme events, of course, with greater expense. The remainder of our community is then designed, because they're not critical, as a lesser performance standard, if you will, at a lower expense. And that's how we balance economy and risk when we build your communities. And this model has actually worked quite well until 2020. All of a sudden, we realized that the concentration of all of our critical services in highly efficient workspaces and schools and facilities actually could kill us. And this past spring, then, we were forced to abandon the many critical facilities that we had built to this high standard and start rapidly repurposing our built environment to distribute those critical functions across a whole host of buildings that were never intended for such uses. Now we don't even know what to call critical anymore. So this paradigm shift demands a new way to think about our built environment, and a lot of important questions that we're now exploring with funding from the National Science Foundation. For example, Shelter, it's widely understood. Your home is the foundational element of human flourishing. It promotes your safety, your security. It allows you to have thriving livelihoods, health and education, and many other dimensions of well-being, even outside of a pandemic. The pandemic, unfortunately, has just forced so much more of our education and livelihoods to operate out of these private residences, who were never designed for these kind of functions. And our research has already revealed that homes are likely to continue to play this role, possibly permanently. In fact, companies have told us, excuse me, that they're more inclined to allow flexible virtual work arrangements where their employees now are actually happy to take advantage of that, to reduce their commutes, to live in a more affordable housing market, and even to balance other caregiving duties. So thus, when this pandemic ends, our homes are likely to remain a critical facility for our families. And thus, we've got to start thinking about how we even design them for a new normal. But 2020 was not just the year of COVID-19. This year, we also witnessed 9 million acres burned in wildfires and a hurricane season that produced a record 30 named storms, which destroyed thousands of structures with tens of thousands of families evacuated. And withstanding that kind of shock actually requires Americans to rethink where we live, and how we build. Our economy and our security can only be as strong as our communities, whose resilience is fundamentally intertwined with the resilience of each building, including each of our homes. So everyday decisions that we make at kitchen tables about how to repair, rebuild, and remodel these homes is going to have a really big impact on our country and its ability to survive and flourish, especially in a time of climate change. Our work has been looking specifically at the impacts of this year's hurricanes in the Gulf Coast, which were all happening during an active pandemic. You can't evacuate when there's an active pandemic because there aren't shelters anymore. This forced families to actually shelter in their homes. Homes that you can see from this image were not designed to serve as that kind of critical facility. So given the newfound criticality, how can we deliver more resilient homes that will minimize displacement in disasters like a hurricane and avoid the compound risk of mass evacuations all during a pandemic? Now, what was most sobering in our study of the impact of the multiple hurricanes in places like Louisiana were the effects on the vulnerable populations. Remarkably, facilities like nursing homes do not have to be designed as critical by traditional definitions. They were not designed to survive major hurricanes just like your homes, which was forcing the evacuation of thousands of fragile residents who were very vulnerable to COVID-19. Our research and case studies even found instances where elderly populations were abandoned right before the hurricane made landfall. Thus, we have to really carefully think about who occupies these spaces and if they have the ability to absorb these strong shocks. Otherwise, we need to start designing these facilities, especially for the most vulnerable, with a far more human-centered approach. And then there is the biggest question that the stewards of our built environment, like architects, planners, engineers, and other design professionals, will have to consider. If this pandemic has created such new and lasting flexible modes of work, then what will happen to our cities? Will people continue to flow away from them? Well, some industry experts already are suggesting this will be the case. With companies no longer needing a massive office building, what will we do with all that vacant space? How will we repurpose our urban environments for this new reality where entirely new modes of virtual work may leave all our buildings obsolete? And how can we seize this opportunity to create social good? COVID-19 is an engineer's most coveted opportunity, a rigorous stress test of our systems and the ultimate failure diagnostic. It is the chance to learn so we can design better in service of all. In this perverse way, COVID-19 is perhaps our lifetime's greatest blessing because it's shining a glaring light on what we have chosen to ignore, but nature is giving us no choice but to see. So we look forward to working now with our eyes wide open over the next 2 years with the support of the National Science Foundation to chart a course for what will be our society's greatest redesign. Thank you.
Thank you so much. Before I open it up for questions, I just have a few comments I wanted to add and build on the wonderful work of my esteemed panelists. And I'm gonna just share very briefly. Oops, 1 second here. Let's see. Okay. So just to kind of sort of wrap up and maybe connect some of the dots between our interesting panelists, I think it's not an understatement to say that it is the end of the world as we know it. As Tracy noted in her talk, the pandemic has exposed fissures that have run deep in our society and in many ways have laid bare some of our greatest vulnerabilities. But I think it's not all bad news, that there is an opportunity at the heart of social calamity, this sort of silver lining in the midst of this perfect storm. Many of the changes I think we're all experiencing are likely to become permanent in one way or another. And that may ultimately hasten societal change for better or for worse. Oops, sorry, are you not seeing the slide either? Hold on. Oops, are you guys not, was that not showing the full screen?
Yeah, we were seeing it.
Oh, okay. Let's see.
We were seeing your presenter view rather than the whole slide itself. I guess that's just a matter of personal preference.
Yeah, I wanted to just use let's see, I'll try to just put it in here as not the presenter view. How's that? Okay, so is that working now? So I think one of the things that I think is really intriguing here is our new normal is really dramatically shifted. And in many ways, just the way that our lexicon has changed in dramatic ways in recent times shows you how we are attempting to normalize a truly abnormal situation. And so what we're looking at is a rate of technological adoption that is dramatically turning or creating upheaval in how we live, how we work, how we learn, how we connect. And these are providing opportunities within infrastructure, whether that's to increase access across the board as people spend more times in their homes, as Tracy mentioned, but it's also about how our cities respond and what's going to be happening as organizations, whether they're able to adapt and to find that opportunity or to unfortunately fold and go under. As we see our cities potentially emptied out with as companies jettison real estate because they don't need to actually have people meet in person. We find ourselves asking questions about, do we need to make that long distance trip anymore? Do we need to actually have that go into that grocery store anymore? We see these new technologies affording opportunities and changing, but we're also, I think, dramatically aware of some of the gaps in that. And when we speak about education, for example, access is not there for all. And so we will be looking at and working with the repercussions for this for generations to come. And so how do we create an environment that allows those to not only access, connect, but potentially thrive? Can technology open up more personalized and tailored educational learning? And then also that we're thinking about how do we change behavior on a mass scale, and that it's really resistant. Any of those appeals, when we ask people and we base it on sacrifice or moral altruism, it hasn't worked all that well for us. That we also need to think about a design challenge here in that how do we put in place the kinds of structures in the built environment and the conditions that will actually position the optimal choices as the easiest choices and as the most convenient ones. So with that, I want to open it up to questions, and I have a few here. One of the first ones I want to start with goes to our registry team, and there has been a lot of interest on the chat with opening up the data. And I understand that, Marie Lynn, you've mentioned that we can't de-identify portions of it, but there have been some follow-up questions from numerous individuals. Are there ways to chunk the data that would allow access to that? So I'm hoping if you guys can talk a little bit about that.
So I'll start, and then Rashida and Jocelyn can add things. So for Texas, where we, so for the Hurricane Harvey registry, which preceded the COVID-19 registry, where we have more than 20,000 registrants. We have census tract level summary data that are available and are publicly downloadable. And you can only do that when you have enough registrants in any given in any given county and in any given census tract within that county. So there will be certain census tracts where the data are suppressed. So those, for Hurricane Harvey, those data at the census tract level are publicly available and downloadable. And we can send a link for how you get to, just look up Urban Data Platform, Rice University. For the registry, we don't yet have enough people in either the Texas and certainly not the Indiana registry to make that kind of a publicly available data set. However, we do create workspaces on our private server, which fulfills all of the rules and regulations of HIPAA. We do create workspaces on our private server for people who want to bring, they have some data that they want to bring and connect to the data that we already have. We create these workspaces for people. So there's lots of possibilities for doing this kind of work. I don't know, Rashida or Jocelyn, whether you want to add something.
I'll also add that as far as sharing the data and results, we do have a public dashboard for the COVID-19 registry. I'll start the instance that we have in Texas. We put that dashboard up when we had at least 200 registrants. So we are in the process of setting up our dashboard for Indiana now that we have over 300 registrants. And we also, we apply a rule of 200 just for providing summary statistics by county. And so we try with our dashboard, we work closely with our collaborators to put on the dashboard information or data that they're interested in so that they have easy access to that information. And also for our collaborators, we also create internal reports with summary statistics that are tailored to their interests as well. But as Dr. Miranda mentioned, as far as having those downloadable data sets at smaller geographies, we need to have more registrants in order for those data sets to be truly informative and not like suppressed in every field.
So a follow-up question from Dr. Vanya Smith. She's asking, how do you control for self-selection bias in the registry? And I would like to maybe add a follow-up to that. How are you actually going out perhaps to ensure that vulnerable populations or disadvantaged populations, especially those with less access, how are you trying to address getting some of those communities into the registry?
So I'll say a couple of things to get us started. So first of all, we certainly have overrepresentation of women in all of the registries we've ever done. This is actually true for every public health registry ever, except like registries about prostate cancer or something like that. So we have overrepresentation of women, but one of the things about the registry is that we're asking about the experience of the household. So the mental health questions are about the individual who are for the individual who's answering it, but the economic impacts and there's any number of questions where we're asking about the household, and that helps a little bit. We do have a series of different strategies for different subpopulations. The registry, it's fully available in both English and Spanish. We have multiple people on the research team who are bilingual, so that helps. With the hurricane registry, we did a lot of face-to-face events with people. Of course, you're not doing that with COVID. So there's a variety of different strategies for getting to different population groups. I'll leave it to Rashida to talk about that. In terms of controlling for the self-selection bias, so there's bias in all data. Anybody who tells you that there's no bias in their data don't trust them. So there's bias in all data. Self-selection problems with registries create, more bias than, a randomly controlled trial would create. But what we do is once we get enough people in the registry, then we take the people who are in the registry and we can compare them to the demographics of the population. And because we have everything geographically referenced, we're able to do that not just, for the county as a whole, but in particular subgeographies. So in, block groups or census tracts or zip codes, whichever, when we do the analysis becomes the most sensible, we're able to say, well, what does the census tell us about what the distribution is and what's the distribution from our registry? So if I look at how people from particular groups are responding to these questions, can I remap those responses to the distribution of the actual full population? So there's a series of methods like this out of statistics that help you control for that self-selection bias. Rashida, do you want to talk about our recruitment of minority individuals and low-income individuals?
Sure. As Dr. Miranda mentioned, prior to the pandemic, and so speaking from our experience with the flood registry, our key means of outreach and recruitment in these vulnerable or hard to reach populations was through in-person methods. And a key part of that is working with trusted voices in those communities. So specifically, health departments have been very instrumental. I will say post-Harvey, they were providing a lot of the resources. The city and the county, they set up recovery centers where people would go to speak with counselors, sign up for resources or receive resources. And so the registry became an integrated part of that process, where when someone went to speak with a counselor, they were administered a paper survey. So previously, having paper surveys available at these centers or going to events with tablets, approaching registrants yourself, explaining the project, and having registrants sign up on a tablet were also another way to reach trusted voices. But now that everything's digital and online based, still building those relationships with trusted voices, but in this case, sending out email blasts or from these organizations that have information on the registry. Previously, we've also hosted or been invited to join panels where some of the other faculty and leaders on our project have spoken with figures in government. They've had a conversation about COVID-19 and how the registry fits into response efforts, and having that on Facebook, a Facebook Live, and also having that recording saved for future outreach, to share for future outreach activities, and to just also working with the ideas. Our collaborators in the organizations we work with, they also have lots of great ideas with food pickup donations that are provided by school districts. So one school district, they offered to distribute flyers. And so that led to what their food pickup in the community. So that led to a constant stream of registrants in one county. And then another organization, they offered to administer the survey over the phone. So in those cases, providing the training for and the resources necessary for the organizations to help us with outreach, and just working whatever creative ideas that they come up with, is how we've been reaching those populations during this time.
I want to just take one last question and put it to Tracy. I'm really interested in, we've talked a lot about this sort of digital access, but a lot of your work also has a very human component. You're there, you work with people. So the very nature of this pandemic precludes some of that more ethnographic work, that work where you can actually, peer into people's lives to try to understand how to design for them. What are some of the ways you see yourself maybe shifting your research and the way you're gathering information and intelligence?
Well, we had to shift things dramatically for COVID. And so I'll just give two immediate examples. From just the understanding of how things performed, one of our blessings in helping after Laura hit in Louisiana, Lake Charles area, is we actually strapped Google Street View camera sets on vehicles and had individuals who were in the region drive cars up and down the road and collected about 700 miles of Google Street View imagery that virtual teams were then going through and tagging to identify failure mechanisms. So we were very adaptive. In our work in the refugee settlements, that was different. We had refugee settlements in Myanmar and Uganda that we worked in to look at these issues, and we couldn't bring anyone in that case, and even people outside the camps weren't allowed in due to the protective bubble. But again, we were able to leverage WhatsApp, Facebook Live, and a couple other digital platforms to essentially localize the response by training members of the refugee settlement to be their own self-evaluators, if you will, to collect 400 survey responses to understand the impacts and the challenges for delivering. This was a Catholic Relief Services project on home beyond walls. What are the 4 dimensions of home beyond physical? That includes, the social and well-being aspects and other dimensions of human flourishing, including emotional and spiritual replenishment. And this was an integration lab project. So required us to adapt, but I would say we had far richer data by not being able to travel or even send others from CRS into the camp, but actually to work a little bit harder to get high quality data, including photographic essays. By giving the ability to take their phones and take us through a day in their life to really represent the impact of the pandemic and their fragile living situation, we had a far richer perspective on their needs for design, and we're able to deliver that back to CRS for a more holistic approach to their support.
Wonderful. I know for myself that this is something that's been really interesting. How do we still get out and have that community touch? How do we connect when that very activity is dangerous? So I just want to end with and acknowledge, I think a wonderful panel. Thank you to our panelists for putting together presentations. Thank you all for the patience in Zoom issues, which will continue to plague us.